Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 21st Virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I'm a personal trainer and the Adult Program Coordinator at the NSYMCA in Northbrook, Illinois. Tonight's program, entitled Shoulder Pain, Injuries, Prevention, and Treatment, will be hosted by Dr. Brian McCall. Illinois Bone and Joint Institute's Brian McCall, MD, will teach us about common injuries to the shoulder along with strategies for prevention and various treatment options. Dr. McCall is board certified in orthopedic surgery and sports medicine. He completed his residency in 2004 at Georgetown University School of Medicine in Washington, D.C. And in 2005, Dr. McCall finished his orthopedic sports medicine fellowship at the American Sports Medicine Institute in Birmingham, Alabama. His specialties include sports medicine, general orthopedic care, shoulder arthroscopy, replacement procedures, arthroscopic procedures, total joint replacement, and fracture care. Dr. McCall is a member of the American Orthopedic Society for Sports Medicine and is on the medical staff for the United States Soccer Federation. As a member of the Arthroscopy Association of North America, Dr. McCall regularly lectures to athletic trainers, physical therapists, and other physicians on current sports medicine topics. Tonight, we are fortunate to have him speak to us lay people to help us better understand our shoulders and what causes us shoulder pain. Thank you again for joining us this evening, and thank you, Dr. Brian McCall, for your time and effort in putting together this presentation to teach us about shoulder pain, injuries, prevention, and treatment. Now, Dr. McCall, please take it from here.
Well, thanks so much, Karen. That was really a nice introduction. I don't know that I deserve all that, but it's nice to be here with you guys tonight, and we're going to cover a bunch of issues regarding shoulder pain. Given the total topic of shoulder pain, injuries, prevention, and treatment, I broke this down into a couple of sections. We're going to talk just a little bit about the structure and function of the shoulder. Then we're going to go through a couple of the common injuries and pathologies that we'll see that should be relevant to everybody out there. So being a broad topic, we're going to touch on a bunch of them, but possibly not go into the detail that you might like. I'd be happy to talk to you guys either by email or in consultation regarding anything that piques your interest. So with that being said, we're going to talk about your shoulder joints and what's the function of your shoulder joint. Your shoulder's there to position the arm in space. It's a really important joint. You use it all the time, and because your hand is kind of how you interact with the environment, you need an extensive range of motion to put your hand out in the places that you need it to do things. For that function to be there, the shoulder has to be what's called an unconstrained joint. So the shoulder essentially is a ball in a socket, but it's a really big ball on a really flat socket. And if you think about a hip joint, a hip has a really deep socket where the bone is kind of constrained. So you don't have the same range of motion through your hip as you do with your shoulder, because you don't need to put your feet as many places as you put your hand. With that being said, the bony anatomy for the shoulder provides very little support to the shoulder structures. And soft tissues are what you need to hold the shoulder in place. And that creates a vulnerability to the shoulder that can create opportunities for injuries. When we look at shoulder motions, to the right, you'll see we can put our shoulders forward into what we call shoulder flexion. Behind your body is into shoulder extension. Out to your side is abduction, and then internal rotation, external rotation. And essentially the shoulder joint will have sliding, spinning, and rotational motions through the ball in the socket. So when we look at shoulder anatomy, we'll see that we have three different areas of the shoulder that comprise the entire joint complex. So when I talk about the shoulder joint, I'm usually referring to what we call the glenohumeral joint, or the ball and socket part of the joint. The glenoid is what we call the socket. The humerus is the arm bone, and the top of the humerus is the humeral head. The acromioclavicular joint is where your collarbone comes out and attaches to the scapula or shoulder blade. And that's an area where you may have heard somebody who had a separated shoulder. If a quarterback gets driven into the turf or something like that, the collarbone can pop up and the ligaments here can be stretched. It's also an area where you can develop some arthritis. And then the last part of the shoulder joint complex is the scapulothoracic joint, so where your shoulder blade rides up and down on your rib cage. And that's an area that we don't usually see a lot of injuries. You can fracture through the scapula, and there's a bursa that lives underneath the scapula that can sometimes cause clicking and popping along the rib cage, but that's a fairly rare thing. When we look underneath the skin, we get down to sort of the big mover muscles that power the shoulder joint. So you have the trapezius that comes down sort of off the spine area and attaches to the collarbone and to the shoulder blade. Deltoid is one of the biggest muscles that will move the shoulder and power kind of in the up and down motion. There's three parts of it. There's an anterior head, a middle head, and a posterior head. So it has some rotational motions as well. The pec major or pectoralis muscle in the front is a big, powerful internal rotator and adductor. And then your latissimus dorsi will come to the back. And then in the front of the arm, you'll see the biceps tendon. So biceps has a long head and a short head. The long head goes up into the shoulder joint and helps depress the humeral head and function within the front split of the rotator cuff. The big mover muscles usually are not main sources of pathology, but they're vulnerable to overuse. You can strain the muscles, and in some cases, you can rupture them. So we'll move to our first pathologic condition, a rupture to the long head of the biceps. So as I was just saying on the other view, the biceps tendon is called the biceps because it has two insertion sites proximally. So a short head goes over to a portion of the bone called the coracoid. The long head goes up through a groove and into the shoulder, and that's an area that can be susceptible to injury. So with inflammation or shifting or wear and tear in this area, or just degeneration, the long head of the biceps will sometimes rupture. Sometimes it's with a trivial injury, sometimes it's fairly spontaneous, but usually the patient will either have tried to lift their arm forward or flex their elbow, and they'll suddenly get a pop and some bruising, and the muscle will come down the arm and form this little peak. We call this a Popeye deformity because Popeye the Sailor Man had a big sort of peaked biceps tendon. This tends to be a cosmetic issue only because the main portions of the biceps are still secure. The person doesn't really lose function. It's painful. It'll cause bruising and swelling into the arm, but it doesn't really need any surgical intervention. Some patients will want it surgically repaired from a cosmetic standpoint. And you know, the typical reply there is you're trading a bump for a scar. Most people that come in with this injury, I'll tell a story. John Elway, when he was quarterback for the Broncos, was having horrible biceps tendon pain in his throwing arm, and nobody could kind of figure out what to do with him. And one day he went through and felt a big pop in his shoulder, and the muscle all rolled up down in his arm. And the doctors taking care of him kind of all scratched their head and said, "Oh, what are we going to do? This guy's, you know, our star NFL quarterback." And all of a sudden, none of the pain was present in his shoulder. His arm was really good, and he played the rest of his NFL career with his arm with a Popeye deformity without any trouble. And then years later, Brett Favre had pretty much the exact same thing, except he was having biceps tendonitis and didn't have time to recover from any other surgery. So we literally went inside of the shoulder and just created biceps deformity by releasing the long head of the biceps. And that took care of his biceps pain as well. The other big mover muscle injury that I'll talk about is a tear to the pectoralis major. Usually seen in people who are active with weightlifting or football. You need to have what's called an eccentric contracture for this to occur. Essentially, the muscle is pulling in one direction where the arm is pulling in the other direction. And so the tendon where it attaches to the bone will rip and the muscle will pull away. What you'll see on exam, usually there'll be some bruising when it's acute. The muscle will actually be more prominent kind of because it's not stretched out to its normal insertion point. This one, you can clearly see that there's a big defect there, but they're often a lot more subtle than that. And you have to kind of have a suspicion of the injury and confirm it then with an MRI. We usually fix these surgically because leaving them, there's usually a strength deficit that occurs. So through a small incision near the armpit, we can go over and grab the tendon, put some stitches in it, and bring it back over to the bone, where we'll put some anchors into place to hold it down. And that works really nicely. When we go deeper into the shoulder, we'll get down to some of the common things that you've heard people talk about within their shoulder. So a bursa is essentially a lubricating sac. You have multiple different bursa through your body. There's one on the end of your elbow that can get inflamed. There's one over the front of your knee that can get irritated from kneeling. And inside of the shoulder, there's a bursa beneath the bone called the acromion that essentially is kind of creating a cushion between the tendon and the top of the arm bone and the bone above it. And that's an area where either from degeneration of the tendon or injury, the bursa can become inflamed and irritated, and it's a focus for treatment from time to time. May need a steroid injection or physical therapy to get the bursa to calm down. And if we're going in to do treatments around the rotator cuff, we'll usually remove a portion of the bursa from that area, as it can create some pain. When we get to the rotator cuff is a group of 4 muscles. They sit right down on the shoulder joint. And as I was saying before, we don't have a lot of bony support for the shoulder. And essentially the rotator cuff is what's holding the shoulder joint in place. So the acronym to remember the muscles of the rotator cuff is SITS, right? The supraspinatus, infraspinatus, subscapularis, and teres minor. The supraspinatus is the most common to be injured. It's one of the more important. It helps elevate the arm and holds the arm kind of in and towards the socket. Subscapularis is the large, broad tendon in the front and can be injured either by itself traumatically or in conjunction with tears to the superior rotator cuff. The infraspinatus comes off of the back of the shoulder blade, sits below the spine of the scapula, so it's infraspinatus. Supraspinatus sits above the spine of the scapula and comes over and attaches to the humeral head. So infraspinatus helps hold the arm bone down and externally rotates. And then the teres minor is a relatively minor component of the rotator cuff, rarely injured. It's at the very, very low back and helps externally rotate and pull the arm down. When we look at what the rotator cuff does, as I said, it's sort of a counterbalance, and it keeps the shoulder joint in place. It's what we call a force couple. So it's balancing the forces the humeral head is experiencing when the deltoid is pulling up. The rotator cuff is pulling down and into the socket. Without the rotator cuff, the arm bone would slide up and out of position, and essentially the humeral head would start to abut the bone above it called the acromion. And if you think about it, the ball and socket that are sort of matched with, 2 mated radiuses of curvatures, think of 2 soup spoons that should nest inside of each other. If one shifts up, now you've got point loading where the forces are all concentrated, and that can start to break down the structures inside of the shoulder. This is a nice way of thinking of what your rotator cuff is doing. It's almost as if a hand is there holding it down, subscapularis in the front, the superior rotator cuff over the top. And to the right is basically the vectors. If anyone is sort of a physics buff, your deltoid would be pulling up and over, and your supraspinatus is going to be pulling the humeral head into the socket, whereas subscapularis, infraspinatus, and teres minor are going to be pulling down. And so those forces should all balance out and allow your shoulder to remain in the socket and just pivot in place. Who gets rotator cuff problems? Well, primarily this is a degenerative problem. And what I mean by that is most people aren't going to have rotator cuff issues until they reach about middle age. The rotator cuff doesn't have a great blood supply, and so the fibers start to break down over time. The rotator cuff also exists in a hostile environment, right? There's a bone above it, there's a bursa above it, there's a joint with joint fluid right below it. And so it's a natural setup for those fibers to begin to tear and fail. And it is more common if people are doing repetitive overhead activities or exercises that put sort of eccentric forces to the tendons within the rotator cuff. Younger people can get rotator cuff irritation. It's rare that a younger person is going to have structural tears to the rotator cuff, but it can occur. Some people who are very loose jointed will cause irritation of the rotator cuff, and repetitive activities, pitchers, volleyball hitters, those sorts of sport activities can cause irritation and fraying to the rotator cuff. Over time, you see a much greater increase in more severe problems to the rotator cuff. If you look at people around the age of 60, 15 to 25% or so will have tears to the rotator cuff. By the time people get to 70 to 80, over 60% will have tears. And you know, under 35 to 40, you really won't see those same pathologies present. Risk factors for developing rotator cuff problems: increasing age. People who smoke will get rotator cuff issues at an early age. Some family histories: if you don't have good connective tissue in your gene pool, unfortunately, you'll be a little bit more prone to developing rotator cuff issues. And people with high cholesterol tend to get rotator cuff problems at a higher rate than others. So make sure you keep your cholesterol low. Rotator cuffs can also be injured traumatically, and if you're over the age of 40 and suffer a dislocation of the shoulder, you need to watch out for rotator cuff tears, because that's often the way that the shoulder will fail as it dislocates. What symptoms do you feel with a rotator cuff problem? Usually it's sort of an insidious, a very slow onset without really a provocation, onset of pain. It's worse with putting the hand in an overhead position. The pain is usually localized to the side of the shoulder, the lateral deltoid, and sometimes even down to sort of the mid-arm. And so patients will come in saying, I hurt down here, and you have to explain, well, that's where your rotator cuff is sort of referring pain down to. Often we'll see weakness with rotator cuff problems, but the range of motion of the shoulder with a rotator cuff problem is usually preserved. So even if the person doesn't have power to raise their arm, as the doctor or another person can raise the arm and move it through its full range of motion. A lot of times people with more severe rotator cuff problems will get night pain. So as you're laying in a sleeping position, you just get gnawing and really incapacitating pain that keeps you from sleep. And that's usually an indicator of more advanced damage. And it's often a sign that some of the non-operative treatments for the rotator cuff problem have a lower likelihood of success. What we'll see within the rotator cuff is a whole spectrum of disease. It's almost like a rainbow of different phases. So when the rotator cuff is intact, you may get what we call impingement or pinching of the rotator cuff between the top of the arm bone and the acromion bone over it. You may get a bursitis, as we explained earlier, where you just get inflammation in the bursa. I put the term tendonitis in quotes because if you look at damage to the rotator cuff, we don't usually have inflammatory cells present, right? It's a degeneration of the fibers inside of the tendon. So treating it as an inflammation, and itis means inflammation, is really a misnomer. So the correct terminology is really to call it a tendinopathy or disease of the tendon where the fibers are breaking down. And then as the fibers break down, we may have a partial tear where the majority of the fibers are still intact, but some have failed. If you think of individual fibers within an entire rope, the rope is still intact, but some of the fibers have given way. And that can occur on the articular or the side closest to the joint, or the bursal side, the side outside of the joint. And then over time, partial tears can become full thickness tears, either slowly by more and more of the fibers failing, and we call that non-traumatic, it's just slowly pulling away from the bone and losing its footing, or traumatic, where you have fibers that were intact but are compromised just from the aging process, and then combined with an injury where the person tries to raise the arm against force and then feels a sudden pop and now has worsening weakness. This is what it would look like if your rotator cuff has torn. The tear usually occurs right adjacent to where the tendon attaches to the bone, and that's something that may require a repair. What are some things that aren't your rotator cuff? Well, when I see a patient that comes in and says, my shoulder's killing me, and they point up here onto the upper trap or the bottom of their neck, that's almost always coming from degeneration of the discs inside of their neck. The exception is sometimes if the shoulder joint isn't moving well, the compensation is to move your shoulder blade around. And so by overworking the muscles around the shoulder blade, some people will have pain up in this area. So you have to tease that out a little bit. If there's pain that's radiating down the arm past the elbow, numbness and tingling going into the hand, that's really radicular pain that's coming from a pinched nerve in the neck. And while it can go through the shoulder, it's not usually coming from the shoulder. I threw in heart attacks as something because every couple of months we'll get a consultation to the cardiac ward where somebody came in with left shoulder pain, and they may get some shortness of breath or some anxiety, and they're concerned that their left shoulder pain is coming from their heart, and the cardiologist will check out the heart and say, nope, not your heart. Let's have a shoulder doctor come see you, and oftentimes it'll be a rotator cuff issue. Frozen shoulder is another pathology around the shoulder. Has nothing to do with the rotator cuff. Usually isn't from an injury. It's a spontaneous onset of pain in the shoulder and a very sort of rapid progression of loss of motion to the shoulder. Most commonly sort of an insidious onset in middle-aged folks. What can you do to keep your rotator cuff healthy? If it's related to an overuse, look at sort of the activity levels. Go ahead and try to identify activities that are putting too much stress on the shoulder, modify those activities. If they're things that you enjoy, there are usually other ways that you can keep up those same activities without putting the same strain to the shoulder. Non-steroidal anti-inflammatories, medicines like Advil and Aleve are available over the counter. Tylenol if non-steroidal anti-inflammatories aren't good for you, if you're on a blood thinner, or if you have kidney problems. If you have partial tears to the rotator cuff, they don't necessarily heal, but a lot of them will become asymptomatic. So about 80%, 85% of partial tears will respond to non-surgical treatment. And that'll consist of physical therapy, anti-inflammatories, sometimes an injection to the shoulder. Some small tears, even if they're all the way through the tendon, are stable and don't really progress. And strengthening the rest of the rotator cuff will help alleviate the symptoms from that. And then if you sort of take time to take care of those small finesse rotator cuff muscles with some exercises, going to the gym, we're often working on our big mover muscles. We don't take the time to work on those little counterbalance muscles. So external rotations with a resistance band, with a towel under the arm can be helpful. External rotations with like a 2-pound weight can be helpful. And even some of the sort of yoga pose, like a bird dog exercise, bringing the shoulder up through a range of motion and just holding it in a static position can help make those stabilizing muscles a little bit better. When is surgery around the rotator cuff necessary? Well, if you completely avulse the rotator cuff, if the tendons completely pull off and there's no power to the shoulder, that's usually something that's going to need surgery. Once a tendon is pulled away from the bone, it has no capacity to go back and reattach itself. And muscles only know one thing, they only know how to pull. So they'll pull away and drift away. If you have full thickness tears that are bigger than usually 3 to 5 millimeters and aren't responsive to conservative treatments, those are things that may need a repair. And if you have partial thickness tears that haven't responded to physical therapy, steroid injections, non-steroidal anti-inflammatories, those are times where a surgery may be necessary. I put in just a quick bullet point on stem cells. Every so often you'll have patients ask, whether it's for arthritis or other conditions, can we regenerate these tissues with stem cells? The answer is, unfortunately, no. There are no stem cells, whether they're taken from bone marrow, taken from fat cells, taken from peripheral blood, that if injected to the area may cause any healing around the rotator cuff or fix one of these problems. Some of them have some mild anti-inflammatory properties, so they can make it feel better for a period of time, but they're not really going to be very helpful. How do we fix a rotator cuff? It's usually done arthroscopically, which means just through a series of small poke holes. We'll go into where the tear is present. You're looking at a tear here and the bone that it should be attached to. We'll put a little anchor into the bone with some stitches and then sew the tendon back down where it belongs. This is a simple repair where it's just a knot of stitches here and here. A lot of the time we'll do what's called a double row repair. So we'll put some anchors towards the inner side, pass the stitches, and then crisscross those stitches so it staples the whole rotator cuff down. And that's a quick outpatient procedure. Afterwards, typically the person has to wear a sling for about 4 to 6 weeks. Physical therapy usually is around 12 to 16 weeks. And there are two main phases to physical therapy. The first is very protective because the only thing holding the rotator cuff together at first are just the stitches. And after about 6 weeks, the physical therapy changes and range of motion is increased, strengthening is increased. Prognosis for most rotator cuff tears is very good, but it's influenced by a lot of factors. The age of the patient is usually the most critical. Repairs over the age of 70 have a higher rate of failure. Repairs under the age of 70 have a lower rate of failure. Even those over the age of 70 often will feel better, even if the tear doesn't completely heal. But it's something you should be aware of if you are somebody over the age of 70 looking to consider rotator cuff surgery. The size of the tear, bigger tears are harder to fix than smaller tears. More tendon involvement can be more complex and can indicate a bigger problem. Chronicity, a more recent tear is easier to fix than a tear that's been there for 10 years. And then if somebody has a workers' compensation injury, the overall outcomes from those tend to be a little bit worse than those that are just injured from recreational activities. We'll go through some shoulder dislocations kind of quickly. Your shoulder is the most common major joint to be dislocated. About 1.7% of the population will dislocate their shoulder at one point. They're almost always anterior. Rarely the shoulder can pop out posteriorly. When we're talking about anterior, it's which direction the ball goes out of the socket. So how do you dislocate your shoulder? Falling out to an outstretched hand, the arm can go up into a hyper-abducted position, or the position of vulnerability for your shoulder is with the arm in an abducted or elevated position with the shoulder in external rotation, and that puts it essentially in the position where it can pop out of the front. The main stabilizer to your shoulder is a ligament called the anterior band of the inferior glenohumeral ligament, and that's what tears when the shoulder gets dislocated. If the shoulder pops out posteriorly, if it's a traumatic issue, it's usually a fall onto the point of the shoulder, and usually this is just a transient shift. The shoulder will pop out posteriorly and pop back into position. It's rare for the shoulder, when it goes out posteriorly, to lock and stay out of position, except in two conditions. People with seizures, because the muscles will all go into tetany or maximal contraction, and you have much stronger muscles to pull your arms in than you do to pull them out. So with either a seizure or an electrical shock, the shoulder will basically get pulled out of the back of the socket by the muscles, and it's often locked in that position. It's easily missed, and so patients that have had either a seizure or an electric shock who are complaining of shoulder pain need to have special attention paid to them. And then people that are drinkers that may sustain a fall that aren't paying attention to the position of their arms will often sustain posterior dislocations as well, and need the same kind of special level of suspicion if they're complaining of shoulder pains after those injuries. So when a shoulder pops out, the arm again is in that abducted, externally rotated position, and the humeral head will go anterior. So here you're looking at a socket and the ball is going forward. There will be a tear of the capsule and the labrum that we call a BANKART tear. That's the doctor who kind of named it. And then a Hill-Sachs lesion, which is where the softer bone of the ball gets impacted by the edge of the socket. The socket is a stronger bone, and so it'll leave almost an indent like into styrofoam. And then the capsule will have abnormal tension to the ligament, and the labrum will be torn off of the front. That happens very, very frequently with shoulder dislocations. I'll show you that in a second. The shoulder, again, is held into place by your capsule, the bony anatomy, the labrum, as well as the rotator cuff, biceps, deltoid. The scapular muscles are helping to keep the socket pointed at the ball. And then there's a negative pressure in the ball and socket, almost like when you're cracking a knuckle. So as the shoulder wants to slide out of place, it's like a Chinese finger trap that's pulling the shoulder back into position. The labrum is the gasket that essentially forms a bumper around the socket, and it's the attachment site for the ligament that's the main stabilizer in the position of vulnerability that keeps it from popping out. When it does pop out, that labrum will tear and the ligament won't have normal tension, and that's a BANKART tear. How frequently is it there? This is a great study out of West Point. It's kind of a seminal shoulder study looking at cadets at the military academy. When they had dislocations, 97% had a BANKART lesion and 90% had a Hill-Sachs, or this little bump in the back of the shoulder. Why is that important? Well, like we were talking about, the shoulder has a huge range of motion, and that comes because you have a big ball sitting on a very small T. The T is increased in its depth by the labrum, that's the bumper, and held in place by the capsule. So if we compromise that, we take a chip out of our golf tee, the ball is going to want to fall out of position, whether that's a piece of bone that's missing, whether that's the labrum that's missing, or the capsule. That's what helps create that tendency for the shoulder to want to pop out and become worse and worse. What does a shoulder look like when it's popped out? This is an anterior dislocation. You'll see that the arm is held in slight abduction or slightly away from the person. They can't bring it all the way down to their side. It's usually slightly externally rotated. You can see this guy's having to hold his hand out in front of him because he can't rotate it down to his belly. There's a hollowness in the subacromial space. The acromion will be really prominent, and then the humeral head is usually palpable in the axilla or under the armpit. They'll not be able to internally rotate it or adduct the arm. And then sometimes they'll get some numbness around the side of their arm because the axillary nerve can get stretched in that area, or sometimes worse numbness, tingling, and almost paralysis of the hand because the brachial plexus, other nerves next to the shoulder, can get stretched in that position. This is what a shoulder looks like when it's dislocated. This is a regular anterior dislocation. This is if the dislocation goes way underneath the armpit. This is called luxatio or recta. This is what Drew Brees had when he dislocated his shoulder. And then some people, if their shoulder dislocates, they may have what's called a fracture dislocation. So the shoulder dislocated and the rotator cuff, instead of tearing, actually pulled off a chunk of bone that's sitting here. As the shoulder gets put back into position, fortunately, this will usually sit back into the correct position. In rare cases, if it's not in the correct position, that needs to be fixed surgically. What do we try to do when a shoulder is dislocated? We try to reduce it as soon as possible, and that will minimize the damage that's done, prevent further injury, decreases the pain, promotes healing, allows the patient to get back into play quickly. How do we put the shoulder back into place? There are lots of different ways. There are diagrams from antiquity because shoulder dislocations have been around for people forever. We don't typically use this exact setup, but the modern versions aren't all that far off from it. Hippocrates gave us one of the most common, which is just traction, countertraction. If you're by yourself, you can put a foot into somebody's armpit and gently pull on the arm and rotate the arm back and forth. Not sure what hospital this guy was in where he doesn't even have socks, but he is at least kind enough to put a towel between him and the armpit. Different version, essentially, of traction, countertraction can be done with sheets and a medical team. That's usually done with a little bit of sedation or a numbing agent placed into the shoulder to allow it to pop in. You can also put the patient on their stomach, hang some gentle weights off of the arm, and then by rotating the shoulder blade, move the socket back to the ball and the shoulder will pop back into position. I've actually done this in my office on a handful of times when patients have shown up with a shoulder dislocation. And their first reaction was to come to the doctor's office. And then this is a dislocation reduction that I like to use. It's essentially putting the arm almost into a figure 4 leg lock. It helps relax the shoulder, and then you can rotate the arm back and forth slightly and pop it back in. After the shoulder is reduced, we usually want to use a sling just to hold the shoulder comfortable, usually 1 to 3 weeks. Once the patient's comfortable outside of the sling, we don't want to have them continue the sling. There's no need to create a stiffness. Stiffness isn't stability. It's just creating a more difficult rehab. And then usually we just put it in a position of comfort for the patient to get some early healing. When can the person go back to activities? Usually we want them to have no pain, normal range of motion, normal strength, normal functional activity, minimal apprehension. Usually some physical therapy is helpful after a shoulder dislocation, at least for 2 to 4 weeks. And that'll help engage the dynamic stabilizers, help the shoulder stay into position. What are things that you should consider for a young person who's dislocating their shoulder? This is the first time a recurrent injury. What's the age of the athlete? Are they in their senior year where this is kind of the last season that they're going to be participating in? Or are they potentially going on to the collegiate level? Or for a college patient, are they going to the pro level? What sport do they play? Is it a contact sport, non-contact sport? Because that plays in a position. And then within that sport, what position do they play? It's a lot easier to brace somebody who's, say, an interior lineman on the football than it is to do it to a wide receiver, or if somebody is, an overhead athlete like a pitcher. What point of the season did it occur? You want to try to minimize how many seasons an athlete's going to miss from their injury. So if you can time it, so if it happened at the very beginning of the season and they've had a propensity for dislocations, you may jump on that at that point, or milk it to the end of the season and jump on it right at the end of the season to get the person maximally back for the next season. How much does it affect their ability to play? And then how unstable was the shoulder? Did it dislocate? Was this a recurrent dislocation? Was it subluxed, which is basically saying that it slid out momentarily but popped back into position, or perched where it didn't quite pop all the way out, but the person felt it shift? And did it happen with a contact or non-contact injury? As the shoulder gets looser and looser, It can happen really with sleep, and that's a time where you sort of have to say that this is not only going to keep happening, it's going to keep doing damage that we may have to fix. So what do we usually say to patients that are dislocating the shoulder? Literature says you should fix it, and you should fix it surgically, because non-surgical management in young people with shoulder dislocations have a significant propensity to keep happening. So if you're under the age of 20, about 90% will keep dislocating. Younger than 30, about 80% will keep dislocating. By the time people are 40, the risk of redislocations is closer to about 20%. So if you can wait it out, if only had one dislocation, if you're a middle-aged person, the stiffness is going to pay off for you. Surgery has a very high success rate, and the more times the shoulder dislocates, the further damage occurs, and it can be harder to get the shoulder to be as stable as it was the first time you had an opportunity to work on it. Times where we would have to do a surgery, you can have something called a bony BANKART. So if you get a fracture of the socket, particularly if it's a sizable fracture, you really have only one opportunity to jump on that and fix that properly the first time. If there's a tear to the rotator cuff, that needs to be fixed. Significant cartilage injuries or loose bodies within the joint. And then if the capsule fails off of the humeral side, that can be more difficult and doesn't heal properly without acute surgery. How do we fix labral tears or stabilize the shoulder? It's usually a minimally invasive arthroscopic procedure. It takes that risk for redislocation down from 90% only to about 5 to 10%, depending on which study you would prefer to read. Usually afterwards, you have to wear a sling for about 4 weeks, and then return to sport is in about 4 to 6 months. So the tear will be along the inferior part of the socket, and the ligaments attached to that tear. We'll usually put a series of anchors in, sewing that back down to the bone. This is what it looks like in the operating room. Patients usually laying on their side, at least the way that I do it. Cameras in the shoulder, and then a couple of portals to pass little instruments. They're usually about the size of a pencil inside. And so we can go in and put an anchor into the bone, and then put some stitches in to hold that back. So here's a tear. Here's creating a nice healing environment with fresh bone for the labrum to heal down to, putting anchors into the bone, and then passing sutures to sew that tissue back into position. And then this is a completed repair where you can see that labrum is creating a nice bumper, and the ligaments are back into a normal tension in that area. When should we not do an arthroscopic repair? Well, in certain patients, particularly if they've had multiple dislocations, if they're young, if they're male, if they're into contact sports at a competitive level, particularly if there's bone loss, the risk of continued dislocations after just an arthroscopic procedure is kind of high. So what will we do? We'll basically use a transfer of a bone block. So we'll go up to the coracoid bone, take that piece of bone with the tendon attached to it, and put a piece to the front of the socket. So we've now enlarged the socket. For the ball to fall out of the socket, it's going to have to traverse all the way over that area. And that works quite well. We'll do that when the bump in the head, remember the humeral indent or the Hill-Sachs lesion, is almost like a pothole. So if our glenoid or our car has a wide enough stance, we can drive over the pothole without falling in. But if we have a bigger pothole, or if we have a narrow wheelbase because the bone has now been eroded, we're going to fall into the ditch and the shoulder is going to keep dislocating. So that's when we would want to usually put a bone graft in that area with a Latarjet procedure. Another way that we can fix that same thing is to fill the defect. Remplissage is a French term that means to fill. So if we have a indent that we have a tendency for the shoulder to want to pop out, we can go in arthroscopically from the front, repair the labrum so we have a normal bumper, we repair the capsule so it's tight again, and then if we put an anchor into the center of that and tie the tendon into that, it'll fill and create an inability for the indent to go off the front. With that procedure, sometimes patients can lose a little bit of external rotation. It tends to be minimal and not a functional issue for them whatsoever. I have a tiny bit more on shoulder arthritis that we'll go through very quickly because I'm running out of time allotted here. Essentially, wear and tear arthritis is a really common issue. Less common to affect the shoulder than it is in hips or knees, but still about 15 to 20% of people will get it. More common in females, people of Caucasian descent, weightlifters, boxers, people who are obese, people who've had recurrent dislocations, history of trauma to the shoulder. And then if you have crystalline or inflammatory conditions like rheumatoid arthritis, that can damage the shoulder as well. Rheumatoid arthritis obviously is not osteoarthritis. We're going to focus more on wear and tear arthritis. So in arthritis, we have a dull aching pain. You can get symptoms through the biceps since it goes into the shoulder. You'll have a loss of range of motion. Typically, external rotation or rotating your hand away from your body is the first thing that will be lost, and then forward elevation will follow. And that loss of range of motion tends to be very slow and progressive. Night pain is also a hallmark of arthritis inside of the shoulder. These are some shoulders with arthritis, and what we'll see is a narrowing of the joint space, a bone spur that comes off of the bottom of the humeral head. This is called a goat's beard osteophyte because it looks like a billy goat's beard. There are cysts and sclerosis present. There are treatments for arthritis, but no true reversal. Injections in the shoulder can be helpful, non-steroidal anti-inflammatories. Physical therapy can help to a certain degree, but can't really overcome motion that's blocked by a lack of joint space and bone spurs and that sort of thing. Gel injections are not FDA approved for shoulder. They're an off-label use. They are approved in Europe. Most of the studies show that as the shoulder joint is more advanced and it's damaged, the effect of those isn't all that great, but for early arthritis it can be helpful. In mild arthritis, we can sometimes go in arthroscopically, clean out the areas of damage and loosen any contractures. It can help for very mild arthritis. For more severe arthritis, it tends not to be all that helpful. Those that do undergo simple debridements have a tendency to move forward with shoulder replacements in the near future. If we do a shoulder replacement, we can do it in a couple different manners. In anatomic shoulder replacement, we're creating a ball and socket that mimics a natural ball and socket. This relies on the rotator cuff to hold it into position. It's a very, very successful operation. It has higher quality adjusted life years compared to hip or knee replacements, meaning patients have greater satisfaction and better functional return from shoulder replacements than they do the others. And they tend to last a good long time with low failure rates. In a shoulder that doesn't have a rotator cuff, what we call rotator cuff arthropathy, you don't have anything that's going to hold the arm bone down into the position. So in those cases, we'll use something called a reverse shoulder replacement. Instead of making it an anatomic ball and socket, we're flip-flopping the roles of the ball and the socket. So we'll put a ball on the socket and then turn the arm essentially into a cup that rotates around the center of rotation. And because it maximizes the function of the shoulder, it makes it easier for the person to raise their arm. It was originally essentially for rotator cuff arthropathy, but it is increasingly used for other problems, even simple irreparable rotator cuffs, fractures of the shoulder, or redo shoulder replacements. In older patients where the rotator cuff isn't reliable, sometimes it's the preferred way to fix the shoulder. If you have a fracture as pictured here in multiple pieces, putting Humpty Dumpty back together again with that is not going to work very well. So if you have a simple fracture, we can put it together with a plate and screws to the left. If it's slightly damaged, but the rotator cuff can be reconstructed, a partial shoulder replacement where you're just putting a artificial ball into position can work. But because the rotator cuff doesn't work perfectly with that, a reverse shoulder arthroplasty usually has a better outcome compared to a partial shoulder replacement for those issues. A recovery after a shoulder replacement, usually a sling for a month to a month and a half, depending on the protocol. Physical therapy is, again, 3 to 4 months. And then after a shoulder replacement, most people can lead an active lifestyle with low impact sports like tennis, golf, or swimming. Don't usually want patients doing heavy weightlifting with shoulder replacements just because it can shorten the lifespan of the implants and cause loosening over time. So I think I went a little bit over the time allotted, but I'm happy to take a couple of questions and we'll go from there.
All right, you're sure you have time for questions?
I'll give you 5 minutes.
All right, deal. So Mark sent us a question in advance of your program saying, conservative shoulder treatment is spread out over several months. When should I seek a second opinion, and will I just be repeating the conservative treatment in another clinic?
It depends on the pathology present. So I'd say that if you have concerns that the treatment is correct or the diagnosis is correct, a second set of eyes, I think after a month and a half of kind of diligent care may be appropriate. But, you know, talk to the doctor who's taking care of you and sort of express the worries. You know, just because the person set you down a course of treatment doesn't mean they don't have a plan to sort of escalate to the next level. So, you know, sort of checking the boxes of the proper care first sometimes frustrates a person. And we don't know when we set off if you're going to be the person that's definitely going to respond to the conservative treatment, or you're going to be the person that ends up having to escalate to a more aggressive procedure. But I tend to take a first things first approach, and cutting corners doesn't tend to pay off. So if you trust the person that's taking care of you, you know, ask them the questions. And if you don't get good answers, get a second voice in the mix.
Great, thank you very much. All right, I've got another one that says, when I lift light weights, approximately 5 pounds, my shoulder has some cracking noises, but there's no pain. Is this a problem?
Usually it's not. So painless clicking and popping are usually part of sort of the structures inside of the shoulder moving past one another. So remember, there's kind of sliding, rotation, and spinning motions happening inside of the shoulder, and the bursa that's kind of cushioning between the prominence of the rotator cuff can make clicking and popping. If it's painful, that's something that you may need to get checked out. But painless popping is really never a real cause for concern.
Good to know, thank you. All right, and I'll give you one more so that we don't go too late. If one has pain to the mid-long head of the biceps, is it related to the shoulder?
If I'm interpreting that correctly, I mean, I think it's pretty hard for somebody to say my mid-long head of the biceps. I take care of a lot of shoulders, and I don't know that I could definitely say it's a long head bicep. But long head biceps pathology often is coming from the shoulder. So shoulder arthritis will cause inflammation in the long head of the biceps. The long head of the biceps in and of itself can get inflammation and tearing. And the biceps is also a location where you'll get secondary changes. So if the rotator cuff has had injury and now all the force is concentrated on the long head of the biceps is kind of the last man standing, and it can start to fray and flatten and cause pain. So I guess that's a long answer for yes, probably if you're having a lot of long head biceps, the problem is probably within the shoulder and not the biceps itself.
Gotcha, and that makes a lot of sense, so thank you. I know we didn't have a lot of time for questions tonight. You'll see on your screen different ways to reach out to Dr. McCall. You can reach out to him and ask further questions, have a consultation with him. Dr. McCall, thank you so much for your time tonight. Thank you everyone who joined us this evening. The YMCA really appreciates your presence, and Illinois Bone and Joint, this relationship is just fantastic. So Dr. McCall, thank you. Thank you everyone for joining us tonight, and have a great evening.
Thanks for having me.